So today I have the great pleasure of interviewing Sebastiano Nutarelli from Sports Rehab in Switzerland. Sebastiano, can you tell us a little bit about how you became to be involved with treating arthrofibrosis and your background?
Yeah, sure. Thank you for having me, first of all, and good morning, everyone. So what happened to me that is quite typical, if you think about all the classic stories of patients involved in the arthrofibrosis, was an athlete and had a minor injury that required an arthroscopy. And then after the procedure, things didn't turn out as expected. So I started having and experiencing some stiffness, some rehabilitation wasn't progressing in terms of range of motion recovery as it should. So step after step, I basically developed knee arthrofibrosis. That's something that I realized along the way after multiple visits and multiple procedures, actually. So I experienced it, to say it in short sentence. So to make a long story short, I experienced it firsthand on myself in the first place.
Okay, thank you. Can you tell me how much of a problem arthrofibrosis is?
Well, I'm a researcher now, also a physical therapist. So if it's possible, I like to try to give some data, because data helps us understand the dimension of the problem. We actually do have something that says us that after an arthroscopy, there is an incidence, that means how often it happens, of manipulation after anesthesia. It can be up to 6 to 8% after an arthroscopy, whatever procedure it was, in between 3 and 6 months. That is a lot if you think about it. And lesions of adhesion, that means surgeon has to scope the knee to, let's say for the moment, get rid of the scar tissues. That is a little bit lower, but in between up to 4 to 6%, again, in between 3 and 6 months. So even just considering this data, the dimension of the problem is not that little, is not that minor. Probably though, these are just the published data. That means the data that were captured by whoever tracked this data. And as clinician dealing with arthrofibrosis, it is probably a bigger problem. And because a lot of people most often are not diagnosed and are sent away from clinicians, and I'm saying clinician in a broad sense. So again, orthopedic surgeons and physical therapists, etc., without being fully or completely diagnosed.
Excellent, thank you. So if someone's just been diagnosed with arthrofibrosis for the first time, what does that actually look like?
You mean when you have a diagnosis already?
A new one, yeah.
Yeah. So let's say, let's try to frame how a knee with arthrofibrosis looks like when it happens. So physical therapist is treating a patient, or an orthopedic surgeon is seeing a patient after a certain week post-op. No one diagnosed arthrofibrosis yet. And there are, let's say, typical signs and symptoms, is mostly signs, such as of an early onset of arthrofibrosis. Usually the range of motion is not progressing as it should. So in terms of flexion and or extension, a lot of arthrofibrosis don't lack extension, for example, they just lack flexion, and not that much. But lacking range of motion in general, it is a sign. Patella can be stiff to different degrees, but it can happen. The joint temperature, so the knee is quite warm, there's an altered temperature, and this warmness of the knee, it could be constant, up to the point of the fact that these patients like to wear shorts rather than trousers, because simply they feel the temperature themselves. There is also a visible alteration of how the knee looks like. That is not swelling, most often is thickening of the different structures. It could be the capsule, could be many others, and then we will go through this in a while. And also patients sometimes report disproportionate pain. That means they have pain when they shouldn't, just touching them, or again, just wearing trousers, for example. So it is something that has something in relation to central nervous system. So therefore there is a sensitization. So signs such as redness, swelling, that are typical with inflammation, that are not that typical. It could be that these knees are swollen or there is some redness, but it doesn't have to. And sometimes this also leads us in missing the diagnosis. And so therefore, let's say that if we can understand this, if we can realize that this is happening, tracking these signs, and we know how to react to these signs, because rehabilitation needs to be changed completely, well, then we have a very good chance to help the majority, the vast majority, probably 95% of these patients in reversing the situation.
That's excellent, thank you. So how about for somebody who's had arthrofibrosis for a long time? How does that look?
Well, that's the second part of the story, and is most often a completely different scenario. Usually there is a classic story. They are all coming from something like, I had multiple consultations, I had an initial procedure. Most often there is a procedure or more than one. It was a minor one, could have been a meniscectomy or a meniscus repair. It doesn't have to be an ACL reconstruction or a total knee replacement, even if these are on the list sometimes. Certain procedures like tibial plateau fractures are, expose patients to higher risk of developing arthrofibrosis. But let's say they went through some procedure and then something again went wrong in terms of not progressing as it should have been. So lacking range of motion, etc. And they got to a point in which clinicians, and again, orthopedic surgeons, physical therapists, possibly others, if they were involved, discharged them and told them that things anyway looked decently fine, or they didn't know exactly what to do. So we found ourselves in a completely different situation in which the treatment options are massively reduced, in which whatever was done, has been done, has to be possibly and typically changed. At a certain point, these knees were forced into more flexion or extension, because with the best intentions in the world, they were trying to help these people in regaining function. But we need to have clear in mind that physical therapy comes first. That's a priority. And until we hit the plateau, that means we try to do things little and often, and to try to regain range of motion, both of the patella and the knee joint. And certain other things we'll possibly discuss later. At the point in which this is not happening anymore, and it's evident, it's clear, things are just flat. There's no improvement, has been no improvement for weeks. We need to possibly involve a surgeon and a whole team. That means also a rheumatologist, and at least they are skilled in dealing with this pathology. And this is complicated simply because there is no training. No formal training in whatsoever school, med school, medical school, physical therapy school. So whoever is involved, he has to be skilled because something happened in their life or career, and so got interested into understanding more and deepening his understanding or her understanding of the pathology. Sometimes we need medication to handle this. Sometimes pain is the main problem. Sometimes central sensitization is. Some others, or a combination of these things. Patients also are in massive distress, psychologically speaking, because of the disruption of their lives. So try to think for a second that all of a sudden you can no longer bend your knee, you cannot straighten it up, so you cannot walk properly, and it is always very stiff. So it always slows you down because it takes time to come back to a normal function, if you ever can. So you're simply pulled out from social life, from resuming work and all these things, and you're massively worried because you understand that what's happening is very serious. So psychological support is something that should be considered as well.
You put that very well, thank you. So you mentioned earlier that you need different physiotherapy approaches for somebody with arthrofibrosis in comparison to somebody who's healing in a normal, healthy manner. Can you explain a little bit more what that means?
Yeah, we've been discussing about this with other experts and other people that deal with arthrofibrosis. Saying experts is not correct. Just a group of people that are dealing with this for a long list of reasons. let's say I'm going to mention a few classic things, but truth is that both surgical approach and rehabilitative approach to arthrofibrosis are more an art than a science. It means obviously there is science behind it. We have a lot of studies and we need to know certain things, but in the end, every patient is different. Every knee with arthrofibrosis is reacting in a different way. We just need to understand what are the factors we are playing with, and we need to consider carefully. And then expertise, that's not experience. Expertise means you develop competence in dealing with something. Along the years, help the clinicians, both from the orthopedic surgical side, involving rheumatologists and the physical therapists as well. So let's say that I would never, if you have a full understanding of what a knee with arthrofibrosis is and will inevitably face, never lie to your patients. That's the rule number one for me. That means if there is a diagnosis of it, or you're making the diagnosis for the first time, that's actually happening quite often. It is fair to frame the situation for what it is, saying, being honest, being detailed, and explaining that what's happening is A, B, and C for a long list of reasons we are not mostly sure about, and we need to change completely rehabilitation. The goal are now recovering range of motion and, let's say, get the knee back on track on a normal reaction post-op. So the main goals are different. Regaining muscle mass is not the goal anymore. And this is a classic thing with knee arthrofibrosis. If you ask whoever, physio, dealing with knees after a certain number of weeks, acute phase, I would say, what's the goal? Oh, the goal is regaining muscle mass and then ability to produce force. And that is absolutely correct. But when you're dealing with a knee that is under an uncontrolled loop, an inflammatory loop, that is the case of knee arthrofibrosis, you just want the joint to get back into some level of homeostasis. So we need to calm down the knee. We need to have clear in mind that muscles, and let's say the quad, or anyway the hamstrings, etc., they are not the goal. It's a joint focused rehab. The only thing we care is to have a happy knee, and a happy knee not for a day or two. It needs to be steadily happy. It needs to be something that is achieved and is not coming back.
Sorry, just on that point, can you say then that there is a concept that's pretty popular out there that we should just push through the pain and that's the way to overcome the problems? If you just keep pushing through the pain, then that's the solution. What do you think about that?
Well, there is solid science behind this, so it's not what I think, it's what we know that is different. If you push through pain, if you're very, very lucky, nothing happens, but you need to be lucky. That doesn't matter if your knee or your shoulder, or whatever you're rehabbing, is going through an arthrofibrosis. If you start provoking pain, the only thing you can get back is a central nervous system producing more pain, because pain is an output of the central nervous system. It's not something that happens in the periphery. So you become the threat. You can actually become what's not liked at all by the central nervous system, that start producing twice the pain. And then in the end, situation gets much, much worse. So with these patients, but not only with them, the classic part of the story, classic chunk of the story is, again, as I said, someone with the best intentions, again, tried to force my flexion. And then also the patient says, and I thought it was a good idea because anyway, it was so stiff. But this is aggravating the situation. It is, again, provoking more tensile stress, more pain. It's a stimulus that provoke more inflammation. So it's a loop that is basically, it's like throwing alcohol on a fire. So it's something you just don't want to do, and it never works. I've never seen this approach working in any other pathology, but especially in arthrofibrosis. Basically
another trauma to the knee.
Yeah, exactly. That's what it is. I mean, it's like if the patient would go through another joint sprain, for example, even a minor one. It just doesn't happen all of a sudden, but in the end, it's overloading the joint. And as we just said, we don't want that. We want something little very often, so that the tissues and the joint can accept possibly along the way, very gently, that they have to let it go. And hopefully this happens. We know that approaches such as the low load, prolonged stretch, that means, again, low load. Our hands as a physio, they apply load and can be quite a lot of load. So low load for prolonged time can actually have better results, way better results than trying to achieve everything in a PT session that is 20 minutes maybe, or 30 minutes, and it's just too much in a short time.
Okay, thanks. That's great. So my next questions are related to people who have arthrofibrosis. Is it safe to exercise other parts if you can't exercise the knee for a while because it's very inflamed? Is it safe to exercise the rest of the body?
Yeah, that's it's a good question, because usually when you have a joint, so in the first place, I'm a sport physio. So what we do is we always try to think about the whole body and all the functions. So you never want an upper body to get detrained because the lower body got injured and underwent a procedure. So you always think parallelly, and at the same time you try to keep in shape the rest of the body. And also we try to do this with regular patients. It doesn't really matter, because cardiovascular fitness pays back in the future. I mean, it will pay in terms of their ability to cope with lactate building up when they will recover in the lower limbs. But in the end, with arthrofibrosis, it is something you want to do for a complete different reason, and I will introduce now. But at the same time, so it is a yes, you want to train and let's say rehab/train the rest of the body, but you have to keep in mind there are some caveats. That means it all depends by how the lower limb reacts. So I have seen patients with knee arthrofibrosis getting on the upper body ergometer, so doing a cardiovascular work and getting worse at the knee level, simply because the whole body was reacting. So metabolically speaking, it is still a metabolic work. If it is too much, it is too much, so don't do it. Also, gravity is playing a role because they're sitting. So they stay in a sitting position for a long time, maybe half an hour. They're doing something very good for the overall, let's say, overall fitness, cardiovascular fitness, but that's not the priority. Priority is, again, getting back the knee to a flat state in which there's nothing else that he wants. Let's say the knee is a person, no one that he wants to tell us. It's not complaining anymore. He's happy again, so we can start over. So if this doesn't happen, it's a good idea to work with upper body, because there is solid evidence that if you ask a patient to do some cardio fitness at a certain level, that means the intensity should be quite high. So again, should be feasible and the knee shouldn't react. You will have anti-pain results. So rather than taking painkillers that these patients tend to do a lot, we have a solid weapon in our hands. That's, say, the internal pharmacy of the body. That is the ability of the body to fight pain, producing endorphins. And endorphins are what morphine is trying to imitate. They in the lab, they try to achieve the same, basically. So why taking painkillers if we can produce them by our own? This is feasible. It works. It's solid evidence-based, but it needs to be. So it's a card that needs to be played carefully. Just having in mind that that's priority number 2. The knee still needs to be able to cope with that without getting any angrier.
That's really interesting. Thanks. Yeah. So what would your recommendation be about using crutches post-op for somebody with arthrofibrosis?
That's again a fine dance on how things evolve person per person. I would say guidelines-wise, if we have to provide guidelines, you want to avoid unnecessary load on the joint for a lot of weeks, at least 6 weeks, just as a guideline again, because again, if they walk, they put all the weight bearing on the joint, and it could be too much. Just walking itself could be an excess of load, and so it's not a normal knee. Even switching from 2 crutches to 1 crutch, and then no crutches, it is not physiologically happening like it would in a normal knee. So if this was a knee with knee arthrofibrosis, that underwent lesions of adhesion, for example, or anyway, a procedure for this condition, you really want to play carefully with every kind of load post-op. So again, homeostasis is the goal. There are patients after 6 weeks, they're doing decently well, but the knee is still somehow warm. They are still feeling some catching sensation or something like that. The fat pad area still a little bit bulkier, or anyway, tends to be warmer than the rest of the knee. So you might say, okay, I want you on crutches for another week or two, because I mean, getting to the final result, to the final goal later, there is no prize for who comes first. In the end, the only thing that matters is recovering. And if you make the wrong choice, sometimes it's too late to come back when the knee reacts. There are, on the other hand, some patients that after 4 weeks, 3-4 weeks, clearly there is no any reaction if they stop walking with 2 crutches and then progressively resume walking without a single crutch, and it's evident that the knee is not reacting. So it could be done, but I would play this very carefully. And again, it's better to arrive later but safely rather than risking unnecessarily to apply load on a joint that is not happy at all. Otherwise, the joint and the surgeon would have not, and the physio and the rheumatologist, whoever is involved, they would have never decided for an arthroscopic procedure.
Very true. Yeah, thank you. So a lot of patience is needed then. Patience by the patients.
Yeah, it is. Again, it's complicated this is not ACL rehab. We run courses on ACL, multi-ligament rehab. It doesn't matter how complex it is. At a certain point, it is easy. We know biological time for healing to a certain extent. So we can provide sort of guidelines to frame what you have to do as a physio, as a clinician post-op. With knee arthrofibrosis, it's just completely different. We don't know if that was the last procedure. Others could come. We don't want to be a part of it. We don't want to contribute in having the patient again into the OR because we went too fast, too soon. So there are no guidelines. There are signs, there are things you have to have in mind. And there is has to be a strong cooperation between all the health professionals involved, and they have to be skilled in dealing with this pathology. That means, again, the surgeon doesn't get out of the scene after the procedure. The surgeon is always there. The surgeon sees the patient with the physio, even once or twice per week, possibly. A rheumatologist is involved, and psychologists could be involved. So nutritionists could be involved. So there are many people that should be involved in this process. And the number one subject is the patient. So in the end, who is guiding rehab is the patient. We need to educate the patient in understanding that he or she has to provide feedbacks in terms of, this is too much. I'm feeling that it's going in the right direction or in the wrong direction. Because every time the patient says, there is something weird, even a small amount of stiffness that is getting worse, whatever, we need to take a step back. We need to make sure that we listen to all the little things that are subtle. And sometimes we cannot see them or perceive them, just the patient can. So we need to play with this carefully. That's why I was saying it's a dance, because the music changes every day, so you basically adapt.
That's terrific. Yes. So listen is the key word, I guess. Listen on time. Yeah. So what would you recommend for the use of continuous passive motion, CPM, post-operatively if somebody's got a history of arthrofibrosis?
Yeah, that's another great question, because around CPM, there are a lot of rumors, and these are coming out of the literature. So again, knee arthrofibrosis is a thing aside, is a story apart. We know that CPM is not needed at all. There is no evidence to support its utilization after, for example, ACL reconstruction, etc. So these publications made clinicians aware overall, so stretching the evidence, stretching the concept that CPM is not useful anymore. Insurances are not paying for it anymore all over the world. So this is a thing that is getting in that direction. Arthrofibrosis, again, is a story aside, and out of the expertise, what we know is actually CPM helps, probably for a variety of reasons. But if we, for a second, step into the OR and try to make an example, what a skilled surgeon in dealing with arthrofibrosis tries to do is never to clean the whole knee out of scar tissue, never to restore the whole anatomy as it was initially, but try to do the least possible to achieve decompression. And this movement has to be maintained, and it's complicated if you don't move gently, constantly, the entire day, the knee post-op. So what we need to do is try to help what the surgeon, to maintain what the surgeon created in the OR. And CPM is extremely useful, probably up to 8, even 10, 12 hours per day. So when you do see, they do say these things to patients, they look at you like you're mad, you're crazy, saying, my day doesn't, I have no time. That's why you should sleep in the CPM. So this is something we say right away pre-op. And that's another pretty important part of the story. That's why I strongly believe we should educate patients in the first place. No surprise post-op. They should know everything in advance, because this is a job. This is actually a full-time job, rehabbing your joint if you have knee arthrofibrosis. So you might end up sleeping in the CPM. Sometimes you cannot sleep. I have patients right now. So for example, we now have through 2-3 patients that were operated in the last week, knee arthrofibrosis, that were operated in the last week here, and we are rehabbing them. And the majority of them, I would say, there were 4, so 3 of them are reacting well. They have no issues in sleeping into the CPM. But one of them, a lady, she's actually just not coping with it. It's just saying every morning it comes and you can see she didn't sleep well. And she's telling me, just this thing is a nightmare. I cannot sleep into it. And so you can't force someone in getting into a situation in which there is a clear sleep deprivation. So lacking sleep, that's another problem, because healing won't happen. So again, that's a dance. In that case, we agreed on trying to, and then if you cannot sleep after a certain amount of time, we'll just get out of the CPM, get some good sleep, because otherwise we have another problem to face then. So depends by how things are going. Anyway, CPM is probably pretty crucial immediately. That means you should wake up in a CPM in the hospital right after the procedure, already moving, and very gently, very progressively increase deflection, because we know that's not a thing for extension. It's an illusion. You can get to 0 or -5. Mainly it's for flexion, and it's for maintaining, again, gentle and progressive range of motion, inflection and extension. And it should be a gentle progression, again. So you don't want to boost it up by 10 degrees per time. You just try to go 1 degree per 1 degree and see how things evolve, because again, final result is the most important thing. So absolutely crucial in our experience. Even if you dig the literature, probably nothing up there rather than someone reporting what they've done. So there is something, but it's not solid.
That's great. And yeah, I guess one of the essential rules for CPM in the immediate post-op period, at least, is to prevent the myofibroblasts from causing all those adhesions to the tissues, which really stick everything up.
Yeah, and that's why I mentioned for a second, I tried to step into the ER for a second, as I said. As a surgeon, what they try to do, and I'm quite often in the ER when we operate on these patients, so it's something I'm very familiar with. You try to separate layers, or anyway, you make layers. The target is to make layers sliding on each other again, but obviously they are in contact. So post-op, if you don't move your joint, this is a sticky environment, so it will tend to scar down and create adhesions anyway. This is just something that's going to happen. One day a patient asked me, why, if you remove scar tissue, they come back? Well, the answer is body doesn't accept cavities, and we learned this very well from abdominal surgery. That's why they try to put barriers in between internal organs when they operate, because otherwise it gets all sticky and you have adhesions, and then you have issues with that. Simply in the abdomen, it's different. You don't need that range of motion. You don't need to bend your knee 140 degrees. So you might feel some traction, but a lot of people after C-section, for example, they have adhesions that to a certain level bother them for a while, and then it goes away, hopefully. But there are adhesions there. Simply it's a different environment. So in the joint, there is less room for and less acceptance for them. So the goal is, as you just said, to try to keep things in motion gently to prevent things to scar back down and adhere back down. If you think and very fast in the suprapatellar pouch or the the interior interval. So these things tend to be in certain knees completely obliterated. It means you get into the joint with a scope, there is no room, nothing. It's completely packed with scar tissues. So you need to do a lot of work, and the surgeon try to minimize it, but anyway, they have to do it. Otherwise, it doesn't restore movement and decompression of the joint. And these things, the patellar tendon, the fat pad, or the scarred fat pad at a certain point, they want to scar back on each other. And the suprapatellar pouch tends to be, the tendency is to get obliterated again, but we need to keep things in motion to avoid that happening as much as possible.
Terrific. So probably a lot of physiotherapists watching this will be thinking, well, what about quad building? That's the most important thing. What would you recommend about quad building post-operatively?
Yeah, so that's probably the most challenging thing to change in whoever, I'm obviously referring to physical therapists, whoever practiced it for a while. And for a while means also a couple of years, it doesn't matter. So this is such a strongly eradicated thing. You really want to do this because you know it helps. So at the beginning, simply forget about it. It has to be a strict and clear instruction. When we started dealing with knee arthrofibrosis here in our clinic, it was just me. Now we have a team of 8 physios doing this. And sometimes, especially for the newly trained, I can see them still having the temptation of doing something anyway, because otherwise the job is not completed. And quad-wise, we just don't have to. We need to make sure that the joint, again, calms down. Muscle will come later. So there is no rush at all. Obviously, at a certain point, so focus should be the joint, not the muscle. But at a certain point, if and when we decide and we realize we can introduce some load, because again, training the muscle means applying some load. So isometric quad contraction, they're fine, the classic quad sets, also because they move the patella up and down, so they contribute in maintaining some patellar movement. So the superimposed neuromuscular stimulation obviously is a good thing. There's a solid evidence for it, but we need to keep in mind that we don't have to stress the joint. So straight leg raise, all these exercises in which the joint is not stressed, you can use you can superimpose the neuromuscular electrical stimulation at a certain point. And there are other approaches like biofeedback. Biofeedback is every study in which they use biofeedback, it got to positive outcomes, better than the group if they were RCTs, comparing two groups, the group without, simply because the patient can see how much they're recruiting the muscle somehow. So they have a feedback, and every time a patient has a feedback, somehow they achieve more. So having a biofeedback is positive. And we could and should mention something that in the last, say, 5 years-ish, even if this is older, got some fame, some name. That's a blood flow restriction training. But it's a tricky thing. So the thing with BFR is it's saving the joint. So it sounds like perfect for knee arthrofibrosis. So you're not loading the joint, but you're loading the muscles. And there is solid evidence to prove that the muscles are reacting well to this in terms of synthesis of new muscle cells. So it sounds great. The point is it goes through, it creates some hypoxia. And there is solid literature, anyway, there is literature saying, proving that hypoxia can trigger a cascade that in the end can result in new scar tissue formation. So again, it has to be, say it's a weapon, it's in the toolbox of the clinician, but it has to be used by experienced clinicians, and only when they judge that it's far enough from the joint, from the surgery, I'm sorry, so that the joint is not reacting anymore. And this is not an easy call at all. Sometimes these joints, they look like things are in control. Arthrofibrosis is just something that happened in the past. So we tend to do things too fast, and then it comes back. So we need to play with BFR very carefully in these cases.
Yeah, I have to say, in terms of that, the joint looking normal and then arthrofibrosis coming back, I have experience of that myself.
Yeah. There's a thing that is worth mentioning for physios, and this is happening. I have no percentages, but quite often means it could be 20, 30%. It doesn't matter. That's anyway a huge percentage. So patients with arthrofibrosis that underwent procedures such as lesions of adhesions or anterior interval release, so arthroscopic procedures, even worse with open procedures, because sometimes simply we are forced to do something more. Sometimes you need to access the joint with a mini open or full open. It's something you don't want to do. Sometimes you have to. Think about arthrofibrosis following total knee replacement, for example. These joints, after a certain amount of time, could be 5 weeks, 6 weeks-ish, they tend to have a sort of a U-turn. That's how I label this. So in a day, well, actually it happens in a few hours, they get worse, but worse in a sensible way. That means the patient is telling you, this is much worse. And you as a clinician should pick this up immediately. That means you see the patient every day, and one day, out of the blue, put your hands on the knee, and the knee is warmer. And so you ask the patient, what have you done? Or how's it going? And the patient says, well, it's stiffer. I don't know what's going on actually, but I just want to alarm you. But it's like, it is worse, sensibly worse. And if you wait, also because these things for the Murphy's Law, they always happen at Friday, late Friday. So there is the weekend ahead. It's a big risk. So sometimes you need to call back the surgeon. You need to call back the team, call back in all of them, or anyway, who is in charge of prescribing drugs and understanding clearly if you have to go through another round of some specific drugs to try to kill the reaction at the start. Because if you wait 2-3 days, like a weekend, it could just be too late. So scar tissues can form overnight. It's really a fast process. It builds up, but when you have an acute reaction, for whatever reason, it could be that the patient doing stairs, stepped down and did something inappropriately, and he's not even remembering this, but it happened, and the knee starts producing hyperinflammation again, and then possibly scar tissue. So if this happens, you want to be fast in reacting and involve the surgeon again, and because this has to be approached with certain drugs.
Thank you. So do you have a main message you'd like to pass on to physiotherapists who are dealing with arthrofibrosis?
Yeah, I think we talked about this at the beginning, but the main message is probably that for clinicians, but as a physio, obviously for physios, there is no one to blame. That's the point. Quite often, and I'm thinking back to the last, again, 4 patients of this week, the pre-op visit that we do together with the orthopedic surgeon, they sometimes they need to blame someone, and it's fully understandable. And sometimes they're even right. I mean, I don't know, but the point is there is such a huge lack of knowledge in relation and training in relation to this pathology across all the health professionals. So from the orthopedic surgeons to the rheumatologists to us as physical therapists, we get zero training in this. So we know nothing, etc. Also nutritionists, that there is really no one to blame, because in the end, when this happens, it's just undiagnosed and it keeps going until at a certain point, quite often because of the stubbornness in a good sense of the patients, these patients ends up in a place in which someone knows about this and they get the diagnosis. But sometimes It was 18 months ago, or it was 3-4 procedures ago that the whole thing started. So the message is we need to get trained. We need to get better in understanding how things are happening. How can we treat these patients? But the main thing, and I run a one-day course on the arthrofibrosis, and the goal is always this, and I try to reiterate this concept every 10 slides-ish. You don't want to be the best experts in the world in dealing with the whole thing, because that's complicated. Plus, either you see 10 patients per week like this, or you will never get there. The point is, if you know what you have to search for in terms of early signs of arthrofibrosis onset, if you recognize them, and you know that you have to switch completely rehab, you don't force the knee anymore, you just gently try to go through flexion recovery and extension recovery, and extension is more important than flexion at the beginning, and you know the patella needs to move and certain things, you save literally probably more than 90-95% of these patients. So this is a reversible condition if it's caught in time. If it's too late, things can be reversed, obviously, luckily, but it's way more complicated. It might need more than one procedure, it might need a long time, and eventually the more we have to do, the more risks we have. Just think about risk of infection with multiple procedures. So the message is try to be very good in avoid this thing to happen, because in the first place, because if you can, well, it will be a better world.
Well, thank you. I really appreciate you sharing your extensive experience with treating arthrofibrosis. So I really think there'll be a lot of interest out there in in this expert primer. Thank you.
Well, thank you for the invitation and for the interview.